centimeter, and then you don't really need to worry about that one. It's most likely fibroadenoma. And this is another example of this killer. These are very dense stromal proliferations and epithelial also proliferation. And we might overcall this. And if you look even carefully, you will find there is a leaf-like architectures, and the pathologist might overcall this as Pathologist tumor. But we need to know we need to communicate with the radiologist. There is a lesion there, it's well defined, it's 2.5 centimeters, it's less than 3 centimeters, so that means not to worry. Many pathologists, and this is really the practice in core biopsy, to use the term fibroepithelial lesion. If you see proliferation of the stromal elements and also proliferation of epithelial elements and see some nuclear atopia, and that's seen in about 20% of cases. When the pathologists use this term, they are usually referring to these entities. They are saying it's maybe fibroadenoma, it's fibroadenoma with hypercellular stroma, benign Pathologist tumors, borderlines, and low grade. But the pathologist needs to tell you what's the most likely diagnosis. They are thinking of Pathologist tumor or fibroadenoma. Cases like a straightforward fibroadenoma, we call it all the way through, we call it fibroadenoma. But our worry is when we start seeing stromal proliferations. When you see stromal proliferation, particularly with mitosis, that worries us to call Pathologist tumors. We have, for benign Pathologist and borderline Pathologist, and even some cases of low-grade Pathologist tumors, we are not brave enough to make that diagnosis alone. We have to communicate with our pathologist and radiologist and ask them, what do you see, in order to make that kind of diagnosis. So these type of lesions, for high-grade Pathologist tumors, we can easily make that diagnosis. For a straightforward fibroadenoma, we can easily make that diagnosis. But those in between, we cannot make this diagnosis alone. We have to communicate with the radiologist to tell us what they are seeing. Another thing, like I mentioned a killer for the pathologist, this is the killer for the radiologist. And if you don't communicate with us, you can easily overcall these lesions. I'm not a radiologist, but I can tell you, many radiologists can overcall this lesion. For us, we know this looks like it's a benign lesion. There is a lot of stromal proliferation. There is a sclerosing lesion. There is some hyalinized area. There is a microcalcifications. We see it also under that high power. And we know this is a radial scar. This is a sclerosing breast region. So radial scar, you know, it's radiologically can be alarming, but for the pathology we can identify it. So if you don't communicate with us, we can miss it, and you also can miss it. So it's seen in about less than 0.5. It's uncommon, but it really needs a good correlation. If we don't do that, we can easily miss it. Radial scar radiologically, this is also another...
Dr. Kushi,